Hello, good afternoon to those of you in the Eastern Time Zone. Good morning to everyone else, and welcome to the Systems for Action National Coordinating Center Research in Progress webinar series. We're very pleased that you've taken some time out of your day to join us and learn about some of the exciting new research going on at the intersection of public health, medical care, and social services and support. So we're very pleased to have you with us. My name is Anna Hoover. I am the co-director of the Systems for Action Coordinating Center, and I am an assistant professor in the Department of Preventive Medicine and Environmental Health here at the University of Kentucky. We have our Systems for Action staff on the line ready to provide technical support if we encounter any issues during the course of this presentation today, but I don't anticipate any. We are very excited today to have with us Elya Kern, who's going to be talking with you about the accountable community of health structures and cross-sector coordination research that they have been doing in Washington State. And Mr. Kern will be followed by commentary from JudyAnn, Bigby, and Elya Moore, who I will reintroduce in a little more depth as we progress through the session today. I also want to point out before we get started that in your online box there, you should have a chat box. And as you hear things and you have questions, please go ahead and post those questions to that chat box. We will make sure to get to those before the end of the call and give both our presenter and our respondents an opportunity to answer those questions or explore issues in more depth that you would like to raise. As thoughts come to you over the course of the presentation, do go ahead and write those down so you don't lose them as we progress. It is now my pleasure to introduce our speaker to you, and we'll get underway immediately because we've got a lot of ground to cover and a lot of really interesting information that I think you're going to be excited to hear. Today our presenter is Elya Kern, who comes to us from the Assessment, Policy Development, and Evaluation Unit at Public Health Seattle and King County. He is a public health epidemiologist and a clinical instructor of health services at the University of Washington. Mr. Kern focuses primarily on health reform monitoring, cross-sector data sharing and linkage, and measuring equity gains at a local level. And with that, I will hand the controls over to Elya.
Thanks so much, Anna. Good morning, good afternoon, everyone. This is Elya Kern. I'm excited to be here today and share with you all a little bit of what we've learned in two counties in Washington State, or two regions in Washington State, rather, around accountable communities of health and how they may impact the sort of data sharing and data linkage that's required to evaluate cross-sector work, including care coordination. So with that, I'll get into the presentation. So I want to begin with the story, why we pursued this research project, what was happening locally when we began to have the ideas of what we want to study. So again, now there are a couple of regions that we looked at, but in addition to sort of looking at this from a research perspective, I also work for the Public Health Department in King County, so I'll also offer from time to time perspective from a practice level as well. So in King County, and this is true in many regions in Washington State, there has been for a long time a large emphasis on grounding health and wellness policies and programs in equity and social justice. And so what follows from that is an understanding of the role of social determinants of health, where we live, work, and play, and how they shape health and wellness at both the individual and the community level. Now there has been for a long time a lot of cross-sector work going on in King County. This slide here shows examples of some existing initiatives in blue that have tried to navigate the relationship between things that influence our health and happiness on the left, social behavior, environment, and genetics, and crises that we try to avoid as an individual or as communities, homelessness, jail, prison, avoidable visits to the hospital and ED, and so on and so forth. Now, for all of these cross-sector initiatives, there have been substantial needs to measure progress towards their collective goals, but at a higher level, measure progress towards equity and social justice. But really, data is needed for this. So in order to measure the progress of cross-sector work, we need to share data and information across organizational partners and sectors. But our current and default state in King County and in most regions of Washington State, and this is true nationally as well for many jurisdictions, is a state of data fragmentation, as we've termed it here. And this really means that data systems are designed to be program specific and largely do not talk with each other. Now this has impact on both the individual care provider level as well as the population health analyst level. At the provider level, providers struggle to provide whole person care. They struggle to avoid care gaps and overlaps in care, to alert other providers to significant events such as someone being jailed and how that might disrupt medication. They struggle to see the impact of social determinants of health such as education or employment, and really to understand the full context of health, given that typically what we're seeing is a slice or fragment of an individual's health or well-being. The same is true on the population level. Analysts like myself, we struggle to provide actionable and timely information, given that we sometimes have to just answer questions using the available information rather than answer really the question that someone wants answered. We struggle to accurately identify disparities, and I'll go over why that's true in a later slide. We struggle to measure meaningful progress if we can only look at fragments of an individual or community. And we also duplicate lots of work, given that across agencies, across organizations, across sectors, we often are struggling with the same aspects of data fragmentation and investing human and financial resources to address the same problems. So we had a sort of theory of change when we began this study, and it began with the fact that across the nation there are many examples of cross-sector local partnerships to address either the fragmentation of services, of health and human services, or the fragmentation of information, of health and human services information. In Washington State, accountable communities of health are one example of this, and these were established in 2015 under the State Innovation Model, which was funded by the Center for Medicare and Medicaid Innovation. The purpose of the ACHs, as they're called, is to accelerate the shift from a costly, crisis-oriented response to health and social problems to placing an increased focus on social determinants of health and prevention in an effort to accomplish better health care at a lower cost, often called the triple aim. Now, ACHs here in Washington State, they're regional coalitions of leaders from a variety of sectors that are working together to strengthen cross-sector partnerships, develop regional health improvement plans and projects, implement Medicaid transformation projects, which I'll refer to in a little bit more detail in a bit, and provide feedback to state agencies around regional health needs and priorities. Though ACH-like structures have gained momentum across the nation, the specific governance, organizational structure, and functions of these novel partnerships were unclear at the time we launched our study. Furthermore, the role and added value of local health and human services departments in the ACH model had yet to be determined. Now, this is public health systems and services research, so we had a primary interest in understanding through these cross-sector partnerships what would be the role of local health and human services departments in building sort of shared data. So the idea here is that by catalyzing new and existing cross-sector partnerships to improve health, we hypothesized that ACHs could support local health and human service departments to use a collective impact approach to build shared data, and that through this shared data we would have a better opportunity to monitor and evaluate cross-sector initiatives, with one example being care coordination strategies. We began this work with the belief that improved data sharing and data linkage wasn't necessary only for measuring progress towards the triple aim, but also to make progress, given that we knew we needed fuller information on individual and community well-being to design better policies and programs. There are 9 ACH regions in Washington State, shown here on the slide. This study involved 2 ACH regions, King County and North Sound Accountable Community of Health, which is comprised of 5 counties. So here are our research questions. In the ACH context, it remained and still remains unclear how the assessment and assurance roles of public health would differ from traditional surveillance and epidemiology. Our study examined the assessment and assurance-related roles of local health and human services departments in the creation and use of shared data in the larger ACH context, as well as in the use of evaluating cross-sector care coordination initiatives that were supported by the ACH. We examined how local health and human services departments build shared data through the ACH environment in order to improve their capabilities for assessment and assurance, and whether care coordination initiatives, which are inherently dependent on shared data, are associated with improved health and social outcomes. So from the methods perspective, what that meant is we sort of had a qualitative component and a quantitative component to this research study. On the left-hand side, the qualitative component took advantage of the fact that this was sort of a dynamic process throughout the 2 years of the study. There were lots of organizational documents, work group charters, routine meetings being formed, and so the research team had the ability to attach themselves to those various activities and products to do qualitative research to identify some of the major themes and what the role of local health and human service departments could be in building shared data in this ACH context. On the right-hand side, we had this idea that when you have a cross-sector partnership or a multi-agency partnership that is aiming at improving health or well-being, that we need shared information across the partners in order to do a good job evaluating progress. And so we sort of tested that idea on care coordination or continuity of care programs, one in Whatcom County, which is one of the counties in North Sound ACH, and one on a program in King County. In Whatcom, the program is called Intensive Case Management System, and the study design was a retrospective cohort with no comparison group. And the outcomes that we were looking at was a pre-post, so before-after being enrolled in this case management program, pre-post change in ED visits and hospitalizations, and also their associated costs. And we had about 130 enrollees during basically a 2-year period. In King County, the program we looked at is called the Jail Health Services Release Planning Program. It's a continuity of care program that selects or triages individuals coming into jails that have a higher need for continuity of care services. So when someone is released from jail, trying to improve their access to a variety of health and human services, such as behavioral health treatment or housing services. The method here was to do a difference in differences analysis comparing the intervention group with a propensity score match comparison group. The outcomes we looked at were a pre-post change in jail bookings, jail days, ED visits, voluntary and involuntary hospitalizations for behavioral health concerns, outpatient behavioral health service utilization, and time to the first behavioral health service post-release from jail. We had 112 individuals in the intervention group that received the intervention during a given year, and 127 individuals in the propensity score match comparison group. Now, actually, for both of these outcome evaluations, the focus for us was less on whether the program worked or not. So the focus was less on what were the outcomes, but really the focus was on what is the added value of sharing and linking data across partners when we're doing an evaluation like this. That's what I want to get into it in the results section. Okay, so moving there. So ACH's local health and human services departments and the path towards improved data sharing, linkage, and dissemination. So beginning with some stuff from the qualitative component of our study. The slides I'm about to show come from the King County Accountable Community of Health, and I think they do a good job of representing some of the lessons learned that were identified around data sharing and also the role of the public health perspective, which is essentially the population health perspective, in building shared data through the ACH context. So in King County, when the ACH was established in 2015, a data group was established to support its data needs. This is called the Performance Measurement Work Group. The group identified over time a couple of values that it was going to operate under. One was that by providing the right people the right information at the right time, we believe we could promote evidence-based decision-making for health policy and programs. The second was that by making available a current, fuller picture of health and well-being at the individual and community level, decision makers would be better able to both gauge and make progress towards collective goals. On the lower section of the slide, this sort of gets to what I mentioned earlier as sort of a belief that was generated or was highlighted during this ACH development process. This is the idea that sort of folks often call data to action. On the left-hand side, we have short-term goals that this data work group sort of rallied around, and those were improved data sharing, improved data linkage, and improved data dissemination. On the right-hand side, these were the long-term goals that the group believed that by meeting these short-term goals, we could directly affect. And those are improved social determinants of health, so where we live, learn, work, and play. The triple aim, which I referred to earlier, of better health and better health care at lower cost, and equity and social justice. Now, very early on, it was clear that when you talk about improving data sharing or data linkage or data dissemination, that you run into a variety of different data perspectives that often conflict, sometimes they're in alignment. In any event, there was definitely a lot of relationship building and convening that needed to take place to help support sort of that collective impact approach, notably giving partners time to learn how to speak the same language around data sharing or data linkage or data dissemination. So the performance measurement work group in King County implemented sort of a multidisciplinary approach from the beginning, borrowing from the city of Chicago's model of describing their data ecosystem. We understood that there were data creators, individuals or entities that create data. We understood that there were data consumers on the right-hand side of the slide, and actually they're the same often. And then there was also a third group of data enablers. So these are entities or individuals who don't necessarily use the data we're talking about sharing or linking for their own work, but they're essential for data to be shared and linked and also to be disseminated. So I'm talking about contract staff who help design data sharing agreements or memorandum of understanding, IT staff that make sure the data infrastructure is there and that will support data sharing or data linkage, legal professionals and privacy officers to drive decision-making around managing risk and compliance around maintaining and using this sensitive information appropriately. And leadership is necessary because a lot of this depends on relationship building across individuals and organizations. And so having that buy-in or commitment at the top level of organizations has been crucial. So operating under this multidisciplinary approach, the performance measurement work group began to identify discrete services that it would provide to the accountable community of health. One was a convener role in relationship building, which I referred to, which was necessary to support this collective impact approach. The second was the recognition that this was playing out in 9 different ways across Washington state. So we have 9 different ACH regions. If we're talking about building a more unified data system or a more unified approach to our fragmented data systems, we recognized that we needed to work across the regions, given that our populations don't stop at our borders in terms of seeking health and human services. So we have and continue to do a lot of multi-ACH advocacy around data, identifying cross-cutting needs and cross-cutting priorities, and using this to try to consolidate a single voice to the state as it makes decisions around investing its dollars in improved data sharing and data linkage. We also generated local recommendations for improved data sharing and linkage for our ACH. We have begun to invest time in a needs assessment that is required for Medicaid transformation projects, which I'll mention more in a bit, and also provide project-specific support around data sharing and data linkage. So these are examples of some of the services that came out of one ACH's data group. Now, one additional thing I wanted to say, in the King County ACH setting, the entities that have played the backbone role for this data group for the past couple of years has been the Public Health Department and the Human Services Department. Now that has differed across ACH regions. In some regions it has been nonprofits to play that role. There have been hospital systems that have been stood up to take major roles in the ACHs. So it varies across the regions, and this is just one example. Now, I mentioned earlier Medicaid transformation projects. For those who are familiar, I don't want to get too much into this, but it is a key sort of pivotal moment right now for the ACHs in Washington state. So I felt bad I would have felt bad if I didn't mention this. This refers to the waiver, the Medicaid waiver, 1115 waiver that Washington state received in January. Multiple states have gone before Washington doing this: New York, Massachusetts, New Hampshire, Texas. In Washington state, there's over $1 billion to invest in health and human services transformation projects, or really delivery system reform projects. These projects are going to be administered through the accountable communities of health. Now, one of the things that has become apparent in looking at the project areas, which are shown here up on the slide, is that there are lots of overlapping populations and there are lots of data perspectives. Now, this sounded familiar to us because we had been talking about these in the ACH circles for the past couple of years, even before there were these concrete projects to dig into. So one of the findings recently has been that given the efforts on building relationships, common language, and trust around cross-sector data sharing and linkage, one example is that we feel that King County ACH is now well positioned to tackle the complicated questions around how an ACH makes wise data investments to support planning, implementation, and performance measurement of Medicaid transformation demonstration projects. One rabbit hole an ACH could go down is thinking that it would be a good idea to develop 9 different data systems for these different projects. Okay. Another mistake could be to think that only 1 or 2 data perspectives are essential to consider when making data investments. So we have spent a lot of time in King County, and other ACHs have done the same, in trying to build a common language around data sharing priorities, data linkage priorities, data sharing barriers, and data linkage barriers, so that when it comes time to make an investment to support a cross-sector initiative like the Medicaid transformation, that those relationships, those common language, those recommendations exist to help support that process. Another example of that is data governance. So data governance is also essential in order for this sort of required data sharing and data linkage to occur. I'm not going to spend too much time on this slide, but just like data sharing, data governance depends upon solid, trusting relationships across data creators, data enablers, and data consumers. And so the work in these 2 ACH regions, including the study, to build the relationships across data stewards to use common language, will also, I believe, support the ACHs in these areas to make wise decisions around data governance. All right. I mentioned earlier how data fragmentation creates a barrier for equity and social justice. And this sort of slide begins to speak or to show a little bit of why that's true. So as I mentioned, data systems are program specific and largely do not talk with each other, and this forces us to depend on population-based surveys and vital statistics for much of our health information. This is particularly true speaking from the public health and human services perspective. Now, while some vital statistics are linked routinely, like birth data and hospitalization, most vital statistics databases and most survey databases are not allowed to be linked for routine public health assessment or monitoring or evaluation. And so what that means is that we have a fragmented view of a whole person. So we might be able to understand someone's educational attainment and their diabetes prevalence, but not together. And the other thing that this means is that we also struggle to understand demographic characteristics, which often are social determinants of health. Because of incompleteness in individual data sets, we often don't have a full picture of that. So what we get when we are able to link data across multiple agencies, multiple databases, is we begin to get a fuller picture of both our outcomes, whether they're health or human service outcomes, but also our demographic characteristics, which are essential for identifying disparities and measuring progress towards eliminating those disparities. So I'm going to get into the outcome evaluation part of this grant, beginning with the example from Whatcom County. Now, in Whatcom County, we looked at a care coordination program's ability to reduce emergency department and hospital use. On this slide, we see what's graphed here is the total prevented number of emergency department visits. The dark blue bar is the total during a 200-day enrollment, which was about the median enrollment. And the light blue bar is the average per individual. So on average, an enrollee saw 1.2 prevented ED visits after enrolling in the program. On the hospitalization side, we see a similar scenario in that we see a reduction. So we see a 50 prevented hospitalizations total, or 0.4 per person. Now, how that translates to cost is on the left-hand side, we see a total of $370,000 prevented due to avoided ED visits. And on the hospitalizations are really expensive, we see $1.7 million averted. Now, no, this is not net savings, as we haven't considered the cost of the program, the care coordination program here. In any event, though, the program did demonstrate, now granted, without being able to compare to a comparison group, it did demonstrate a reduction in utilization and in costs. Now, with that, we didn't have a comparison group here, but one of the things we did do is we recognized that demographic and baseline health characteristics, such as behavioral health concern status, would be correlated or related to how long a person was enrolled in. And so we did use a propensity score matching approach, or not matching, a propensity score approach to generate the likelihood of whether someone would drop out of the program early, depending on their baseline demographic and health characteristics. And we included that likelihood in these models in order to help adjust for the fact that we didn't have a comparison group. I'm going to go to the King County program here to show a different approach and begin to paint a picture of why data sharing and data linkage is essential. So in King County, we took an existing continuity of care program, the release planning program. But in the past, the evaluations of this program had only been able to consider criminal justice outcomes, such as coming back to jail. Now, this was a problem because the program wasn't designed to improve criminal justice outcomes. It was designed to improve health and well-being. And so it wasn't really being empowered to look at the outcomes it was designed to target. The reason it wasn't is because of data sharing and data linkage barriers. So what we did here is we thought that we could do two things to sort of suggest or offer up a new approach to program evaluation for these sorts of programs. One was to create a comparison group, and one was to look at outcomes beyond just criminal justice domain. Now what that meant is we were going to have to share and link data across organizations. And this sort of slide deck, without going into the details, it shows the level of data sharing and data linkage that was required for this one program evaluation. We did share data across 4 organizations in King County, Washington State. One was King County Jail Health Services for electronic health records. One was the King County Department of Adult and Juvenile Detention for booking data. One was the Washington State Healthcare Authority for Medicaid claims data. And one was our King County Behavioral Health and Recovery Division for behavioral health treatment data. Now, one of the things we were really excited about was using a propensity score matching approach to address our past challenge of not being able to have a comparison group. So now, linking data across those 4 agencies' databases meant that we had a lot of rich demographic and baseline health and human services information. So what we were able to do is look at differences between the intervention groups, so those that receive release planning, and everyone else who didn't get release planning during the study period. So that was the unmatched comparison. And we saw huge differences noted by the width of these black bars in baseline bookings, baseline jail days, so these are criminal justice factors, behavioral health concern, chemical dependency concern, and number of chronic disease diagnoses. Now this all made sense because, again, this release planning program triages individuals to receive this service. It is selecting individuals who have the greatest need for continuity of care services. Now, age, sex, race, and Hispanic ethnicity, we didn't see huge differences. In fact, the differences between the intervention and the unmatched comparison group were not statistically significant, but we still feel it's important to include these in our propensity score model. So the propensity score matching, the way the model works is it strives to find a matching individual in the unmatched group for every person in the intervention group. The blue bars show the differences between the intervention group and the matched comparison. And so if the model works successfully, what you want to see is these blue bars shrink as close as possible to 0 on this sort of standardized difference scale. And this is what we saw. For the characteristics with which we saw huge differences in the unmatched comparison, baseline booking, baseline jail days, behavioral health concern, chemical dependency concern, and number of chronic disease diagnoses are all shrinking towards that 0 threshold. So what that meant then is we then felt comfortable to go on and do our differences and differences analysis, which is basically to look at, okay, well, did the program have an effect across these various outcomes? Now what we found is not a significant difference in jail bookings and jail days, which that's okay given the program wasn't designed to target those. I want to highlight the 2 findings at the bottom, the outpatient behavioral health services and the days to first outpatient behavioral health service after release from jail. Now again, this program triages individuals because they have a higher need for continuity of care services. One of those is demonstrating a behavioral health concern. And so the program staff, when they saw these findings, were really happy to see that for the first time, given that this data, they hadn't been able to look at this data before, that individuals who received the services received 21.7 more outpatient behavioral health services in the year after release from jail compared to the matched comparison group. Similarly, they used their first outpatient behavioral health service 55 days sooner. Now, this is just the beginning. This is just the tip of the iceberg. We would like to look at additional outcomes, more meaningful outcomes. But again, the point of this study was to demonstrate the added value of shared data. So here's our legacy in King County, a landscape where data systems were designed to meet the needs of a single program or agency with limited opportunities for meaningful sharing of data, both within and across organizations. Now, moving forward, if I had to identify sort of one critical thing we've learned, which is not a new learning nationally, we've heard this echoed by lots of jurisdictions, is that data moves at the speed of trust. So at the core of the ACH model is the idea that improving population-level health requires cross-sector collaboration that reaches beyond the traditional healthcare delivery system. The inclusion of community-based organizations and the acknowledgement of social determinants of health are essential components of this ACH approach. Our study found that trust is a required building block for ACH-like structures to develop care coordination structures and share data assets. The most effective way to build trusting relationships across ACH partners will vary across regions, across areas. Collective impact approach may be one successful tool. Specifically, ACHs may be well served by dedicating time to identifying the mutually reinforcing roles of their members, given that successful cross-sector health partnerships require diverse human and material resources, including leadership, funding, subject matter experts, policymakers, analysts, and IT staff, legal and privacy officers, and care providers. In most cases, and this certainly has been true locally, building the trust required to collaborate and share data takes years, and thus health improvement projects should be planned accordingly, although we certainly hope to accelerate this process over time. As the Medicaid demonstration unfolds in Washington State over the next 4 years, Washington's ACHs will have ample opportunity to improve data sharing and data linkage on an unprecedented scale. Strong partnerships and work grounded in equity and social justice will be necessary to ensure that what we build towards is truly a fuller picture of individual and community health and well-being. Thanks so much. I just want to acknowledge funding for this project from the Robert Wood Johnson Foundation, as well as we have a research team here in King County and North Sound as well, and a number of strategic advisors that provided valuable advice to this project. For more information, feel free to contact me, and we'll now turn to the moderator.
Thank you so much, Eli. We will be coming back to your questions, so if you have a question, please do be posting those in the chat box. But first, we're going to take a moment to hear from our esteemed commentators. It falls to me to introduce both of them, and then I will hand the mic over so that they can speak one after the other. First, we are joined today by Dr. JudyAnn Bigby, who is a health policy expert with a broad range of experience, including more than 25 years of primary care internal medicine practice. Her areas of expertise include primary care design and integration with public health, state health policy, primary care transformation, and integration of physical and behavioral health with a special focus on women's health, minority health, and health disparities. Dr. Bigby led a project for the Ohio Department of Health to assess the effect of Medicaid expansion under the Affordable Care Act on public health programs, and she led an evaluation of the Oregon 1115 Medicaid waiver demonstration on how the demonstration transforms the delivery of health care to improve access and quality. Previously, Dr. Bigby served as Secretary of Health and Human Services for the Commonwealth of Massachusetts, where she was responsible for implementing many aspects of the 2006 Massachusetts Health Care Reform Law. She served as Director of Brigham and Women's Hospital's Community Health Programs, in addition to designing clinical programs and conducting community-based research to eliminate health disparities among low-income and minority women, particularly related to breast and cervical cancer. After we hear from Dr. Bigby, we will hear from Dr. Elya Moore. Dr. Moore is Executive Director of the Olympic Community of Health in Port Townsend, Washington. With 12 years of training as an epidemiologist and 6 years of experience leading a local nonprofit health collaborative, Dr. Moore is grounded by the belief that healthcare is local, and therefore solutions to the problems that exist today must derive from the local experience. She drives toward improved population health by blending her experience and training with her passion for supporting communities. I now will hand the microphone over to Dr. Bigby first.
Thank you very much, Anna. And thank you, Eli, for a very inspiring presentation of a very challenging, I think, project. Lots of lessons to be learned from the work that you're doing. So I really like the fact that your research is focused on understanding how data sharing and data sharing systems can be used to improve population health and reduce disparities and increase equity. The issue about data sharing is such a big barrier. I know from my own experience that in addition to some of the barriers that you described in your earlier slides, there sometimes are local governmental actions that prevent entities from sharing data, and so engaging government in understanding the barriers that exist, I think, is one of the issues that I hope to see addressed in future research. What I really liked about the work that you're doing is that it really is allowing us to learn more about how to bring people together toward a common goal of data sharing and for very clear purposes. I especially liked the framework that you described in slide 15, where you identify the data creators, the data consumers, and the data enablers, because that really is at the juxta of how we get these systems to work together. Applying the use of data that can be shared across systems is a very important concept for those of us interested in cross-sector collaborations and the outcomes that that can achieve. And when I think about what you're trying to do, developing a research project that shows the potential impact of this cross-sector analysis and the use of data, I think has to consider a couple of things. Other issues that come up that make it hard to understand the impact of cross-sector analysis is what is the structure of the systems that are collaborating with each other. So if you can share data but the provider system hasn't really changed very much, what kind of impact is that going to have on the outcome? What kind of incentives are there for providers? The other thing that I think is very important to think about is how that data can be used, not only at the population level, but also at the system level. And while you describe the importance of a population approach, the information that you've given us in terms of the outcomes that you tracked are at the system level, which I think is a really important concept, because what we want is for people who are making policy, developing improvement in the systems to use the data that they collect for the population they're serving to inform their strategies for improving systems. So focusing on the ability of providers and managers to use that system-level data, which is really a subpopulation, I think is an important part of what you are trying to study. The only other thing I will conclude with is that the Affordable Care Act included a provision that allows states to design systems from Human Services and the Medicaid program to work together. I don't know whether Washington took advantage of that, but I think it would be interesting to understand more about the impact of the Affordable Care Act and how states either took advantage or were not able to take advantage of some of the policies in the ACA.
Thank you, Dr. Bigby. Dr. Moore?
Hi, yes, thank you. So I always find Eli's presentations inspirational, and I really appreciated the comments from Dr. Bigby. I'm not sure what part of the ACA you're referring to. We are rolling out a Medicaid waiver, a 1115 waiver, that maybe Eli knows. But I'll run through my comments here quickly and just say that, as an executive director of one of the 9 accountable communities of health, a nonprofit, I have found great fruit in the private-public partnerships between the ACHs and the local health jurisdictions, and I think this is a really great example of how that partnership can work. Public health has a strong track record of population health analysis. They understand the levers that drive health at the population level. They have the technical expertise to do this kind of work that Eli's talking about, this kind of data harmonization and brokering data sharing agreements across organizations and sectors. I think it's also important to point out that in the healthcare world, there is inherent competition. Competition for patients, competition for market share, competition for contracts. And what public health really brings is this arbitrator of data. And it's something that while you would think an accountable community of health can really step into that role, I remind everybody that accountable communities of health are really young. And our role in this convening and engagement world has not really developed these skills. And what Eli said about data moving at the speed of trust, public health holds those relationships. They hold the historical institutional knowledge. They know the political nuances to get the data to move. So it makes a lot of sense for accountable communities of health to lean on their local health jurisdictions to help the data move. And to work hand in hand with them, particularly around the demonstration, to make sure that the role of public health as this evaluation hub is able to really deliver and do what they do best. I wanted to point out that in terms of data moving at the speed of trust, another nuance of the Washington landscape is the 29 sovereign tribes that we have. And in the North Sound ACH, there are 8 tribes, and in the current ACH that I work within, there are 7 tribes. And data is a very sensitive topic for our tribal partners. And this is, when you talk about health equity and addressing social determinants of health, talking with tribes about how they view data sharing is a whole nother domain. And what public health has done over the years, largely due to the emergency preparedness work and role that public health holds, is they have been working with tribes for years around data sharing to support the people in the event of a natural disaster. So those relationships work and they're in place, and they're really important to leverage. From the medical clinical perspective, there is a massive need for interoperability. And as an ACH, I work with all sorts of clinical partners, behavioral health, hospitals, clinics, specialty, long-term care. And when I talk about interoperability, I literally see a little glimmer in the eye, and it's become very clear to me that providers want their patients' care coordinated. It's not, they don't want to be a barrier to that, and what I hear from them is the desire to push information to them and not ask them to pull it that extra click you hear all the time in primary care. Don't make me enter data into another system. These reports should be automated. I should be triggered. These sorts of technological advances exist and are there, and the role of accountable communities of health with public health in bringing these technologies online and able to move data from one place to another. And I'll end with this notion of interoperability. As an accountable community of health, we do Medicaid consumer interviews, and Eli showed the slide of the various projects in the demonstration. And I did a qualitative interview of one in particular Medicaid consumer about each of these projects and said, what do you think about this project? Would this be of value to you? How can we make it better? And when I get to the question of interoperability, and of course I'm talking about sharing information so your providers can talk to one another, she said, and I think this was probably summed up the interview in a sentence, well, don't you guys do that already? And when I shook my head, she said, you don't? Well, you need to do that. And it just dawned on me that that really, this is on us to make these, to grease the skids and make this happen. And as interoperability becomes a reality and we start to see those efficiencies, I think we'll need to see the financial reform to follow, because we will reduce emergency visits, we will reduce hospitalizations, and we will increase preventive visits, we will increase behavioral health visits, as Eli's preliminary data already showed. And we need to make sure that the financial structures are in place to support that kind of reform. And I'm really happy to say that in Washington State, our state is moving forward at a pretty fast pace with value-based purchasing to make these efficiencies actually incentivized in the years 2018 to 2021. Thank you for the opportunity to comment.
Thank you, Dr. Moore. And again, we encourage those of you who are listening to enter your questions in the chat box. We do have a couple teed up right now. The first is from Tim Fletcher, who wonders whether the diagram on Medicaid transformation that you see here, I've gone back and pulled up that slide, is that diagram published somewhere?
This is Eli here. It is not published, except that you have access to these slides, so you're welcome to use it. But I should caution that this is sort of a rough approach at a slide that's being used for planning right now as we speak. And so this was just my attempt to look at how the target populations across Medicaid demonstration transformation projects in Washington State overlap. Given the entire Medicaid population is the overall population, these different project areas have huge overlaps, and this was just a slide I made to drive home the point that we should make wise investments in data infrastructure to support each of these projects.
Thank you, Eli. Our next question comes from Ned Gardner, who comments that it was a great presentation and wonders, what metric or instrument did you use to assess changes in trust?
Eli here. We did not assess a quantitative change in trust. That was actually something we considered, not actually for the research study, but the King County ACH Performance Measurement Work Group did consider issuing a recommendation to the ACH that this be measured. But it didn't rise to a high enough priority, given that there was so much effort actually just placed on getting data sharing agreements drafted, linking data. But it's something that we're still really interested in, and I'd love to hear from anyone on the call if they've heard of anything like this being done in any jurisdiction.
Thank you. One other question. In your method, you've also done participant observation, and you broke out the data creators, the data enablers, and the data consumers a little bit later in the discussion. I'm just wondering if during participant observation, any marked differences across these groups in terms of barriers or facilitators to data sharing, or that might flag a way for us to approach interoperability in the future. If we saw folks who, any of those particular groups who you saw as being particular catalysts for that work.
Yeah, it's a really good question. I mean, each of these fields or professions, as they're described here, brought different strengths and different limitations to the group. And so I could say, for example, leadership, I mentioned how it's essential, given that there has to be excitement at a leadership level in sharing data, and that can help put staff who are dealing with challenging questions like, are we allowed legally to share and link this data, could put staff more at ease if they have direction coming from leaders. More what I would say here is there was just at the very beginning, without building the shared language, there was almost inevitably a conflict between the different perspectives around data sharing, from the analyst perspective, from the healthcare provider perspective, from the IT staff perspective, and from the privacy officer perspective. We all were thinking about different priorities. The privacy officers, understandably, were largely focused on restricting the sharing of data to the absolute minimum necessary, right? I mean, we can think of that phrase coming from HIPAA, for example, minimum essential information. IT staff were thinking about efficiency from the IT infrastructure perspective, which wouldn't necessarily always lead to what would be most useful for the end users. At the same time, I can speak from the analyst perspective. I was just thinking about what I wanted to have access to answer certain questions, to provide actual information to decision makers, and that didn't mean that I was always thinking about the IT considerations, like how much storage would be required, how expensive would this system be, what sort of staff time would be required to maintain this data warehouse, those sorts of questions. And so really, the essential piece here was making sure that from the beginning, these different groups were included in conversations that were aimed at building a shared language around the mutually beneficial aspects of data sharing and data linkage. Because if we were to bring any of them too late to the conversation, there's already sort of this process that would have occurred where we would have undervalued their input. And the key here is that everyone has an equally valuable perspective to bring if we expect to arrive at an effective data governance solution.
Absolutely, and too often we don't know what we don't know, and if the folks aren't at the table to tell us we don't know it, we're left with a dilemma partway through the project. We have a comment from Annette Gardner, reaching back to our previous discussion about measuring trust, and she says that the Amherst-Wilder collaboration factor is a fairly easy instrument to administer and tabulate. It can be used to assess changes in collaboratives on several dimensions, including trust. So there's a bit of information following up on that last discussion for anyone who is interested in pursuing that issue of change in trust on this or similar projects. All right, I see we are approaching time, so I want to take just a moment to again thank our terrific speakers today. First, to thank Eli Kern, who did such a terrific presentation on the research that he has shared today, as well as our commentators, Dr. JudyAnn Bigby and Dr. Elya Moore. It has been a pleasure having all three of you with us today. I'd also like to invite those of you on the line to consider joining us for some of our upcoming Research in Progress webinars. We have sort of a special edition coming up this Friday with Dr. Ted Smith, the Chief Executive Officer of Reverend Systems in Louisville, who will be talking about large-scale real-time asthma event monitoring, civic tech, and public policy. Coming up in July, we have Beth Tarini talking about improving the efficiency of newborn screening from collection to test results. We then have Bergen Nelson coming up later in July on clinical community partnerships and 2-on-1 technology to improve early childhood development. Then in August, we have Danielle Varda and Adam Atherley talking about hospital investment and interaction in public health systems. And then a little bit later, toward the end of August, we have C.B. Mammerl discussing comprehensive population health systems and hospital uncompensated care costs. Again, we thank all of you for joining us for this Systems for Action Research in Progress webinar. We hope that if you're not already, you will follow us on Twitter at Systems for Action and spend some time on our website getting to know the programs, and the work being funded through it. We are a National Program Office of the Robert Wood Johnson Foundation, and we thank you again for your time. Have a terrific rest of your day.